recording, you can put it on the computer rather than on the cloud. Maybe space constraints.
Computer தான் போட்டிருக்கேன் மேம். கம்ப்யூட்டர் தான்
Yeah. Sure.
Play. It's not coming. Where here? Not coming.
What, Mamta?
Ma'am, full screen actually recording started and my full screen went off, ma'am. I'm not able to start PPT play.
No, go to slideshow. What is happening if you're going to slideshow?
Ma'am, below one play symbol is coming before, ma'am. Now it's not showing here down.
You supposed to start.
No, is it changing? Just to change the slides, whether it is changing.
Ma'am, changing. But
yes, it's changing. It's changing. You can go on the top. Top, there is one slideshow option. No?
Ma'am, it's not working, ma'am.
I feel that's fine that you can present with this itself.
Okay, ma'am. Okay,
I think we have got 22 participants. Dr. Rabindran, do you want to take over the conduct?
Yeah, ma'am. Good evening. This is Dr. Mamta Patel from DM Resident. She is going to present a case of a cardiac block in a newborn presentation. And she is a DM resident, and I would ask Mamta to straight away go with the presentation in the interest of time. Any questions will be addressed at the end of the presentation. And over to you, Dr. Mamta.
Good evening, everyone. Today I'm presenting an interesting case of congenital heart block with fibroelastosis. This baby born to 30-year-old primigravida mother, product of non-consanguineous marriage, and the first trimester was uneventful. Initial scans were normal. The antenatal scan done at the 20th week showing ventricular bigeminy. The same day they did fetal echo, it was showing congenital AV block plus bright and echogenic tricuspid valve and left ventricular outflow tract was also bright. That was suggestive of endocardial fibroelastosis. This was the umbilical artery Doppler done at the 20th week showing ventricular bigeminy. Fetal echo done and the cursor was cutting at the atrial and the atrial through ventricular level. In the M mode, it was showing like that. This is A indicative of atrial contraction and V is indicative of ventricular contraction. Not every A is conducting V. Four-chamber viewer. It was bright and echogenic tricuspid valve, suggestive of fibroelastosis, and left ventricular outflow tract was also bright in nature. We evaluated the mother after diagnosing congenital heart block in the fetus. This is the antibody profile for the mother, showing SSA strongly positive and R50 dominant antibody strongly positive. dsDNA was negative and other are also negative. After multidisciplinary counseling, parents opted for continuation of pregnancy with the high risk. Mother was started on tablet hydroxychloroquine, 200 milligram twice a day. She was under close follow-up with scans every 2 weeks. At 22 weeks, scans showed decreased myocardial contractility and fetal bradycardia. Subsequent scans showing the same fetal bradycardia, no evidence of fetal hydrops. The MCA Doppler done at 33 weeks of the gestation was showing fetal bradycardia. Heart rate was around 51 beats per minute. Delivery details. Antenatal steroid coverage was done. Elective LSCS was performed at 36 weeks plus 2 days. Baby cried soon after birth. Apgar being 7 and 8 at respectively 1 and 5 minutes of the birth. Baby was stable in room air in the initial hours. Heart rate was around 55 to 65 in initial duration of the birth. No clinical feature suggestive of hydrops. Anthropometry-wise, birth weight was 2.36, between 3rd and 10th centile. Head circumference 32.5, between 10th and 50th centile. Length being 44 centimeters, between 3rd and 10th centile. Initial few hours started on low flow nasal cannula with FiO2 21 to 25 at 3 hours of life in view of desaturation. After that, baby was maintaining perfusion and saturation. The initial ABG was normal. We did ECG. ECG was showing complete dissociation between atrial and ventricular conduction. The blue color was showing the atria conduction rate, and the beneath that arrows showing were showing a ventricular beating at its pace, and the ventricular are beating at their own pace. Pediatric cardiologist performed bedside echo that was showing mildly hypoplasia of right ventricle, mild TR, contractility was good, and ASD 7 mm that bidirectional shunt, and PDA 4 mm with bidirectional shunt. At 14 hours of life, venous blood gas was showing elevated lactate. Clinical sign of perfusion and BP were within the normal limit. Bedside echo screening was showing good cardiac contractility. Baby was under continuous clinical and investigational monitoring. Repeat ABG after 4 hours was showing increasing lactate trend. Lactate was 6.7 at that time.
Silent.
At 24 hours, baby was having tachypnea and grunting, started on CPAP support. In view of gradual deterioration for intuition were applied, the septic workup we have done, and antibiotics started. ABG was showing pH of 7.23, bicarb was 11, base deficit was 11, and lactate was increasing 9.2. 30 hours of life, perfusion worsened for pale. Baby was of pale color with low volume pulses. We started isoprenaline infusion and a planned pacemaker if after isoprenaline there is no improvement in the heart rate. At 36 hours of life, there is no improvement in the clinical condition. ABG was showing severe metabolic acidosis and rising trends of lactate. Tried bedside transvenous temporary pacing. It was unsuccessful due to difficulty through the tricuspid valve. So we shifted the baby in OT and a temporary pacemaker inserted under the fluoroscopic guidance. Further course through 36 to 60 hours of life, there is no improvement in perfusion. Heart rate was not getting paced. Considering that there is a poor attachment of pacemaker to right ventricular wall, baby was taken up for the surgery for permanent pacemaker. Permanent pacemaker was inserted at around 60 hours of life. Intra-op, baby was found to have hemopericardium, around 50 to 100 ml hemorrhagic fluid drained. But the temporary pacemaker perforated the myocardium of the arterium and caused pericardial hemorrhagic effusion. That is a strong possibility. The X-ray after pacemaker insertion. Further course, post-operatively, baby had refractory hypotension, not responding to multiple drops and injection hydrocortisone. Developed severe oliguria, worsening edema and AKI. Started on peritoneal dialysis. Applied the antibiotic to meropenem in real. There was a capillary leak features were there. IVI and albumin infusion were also given. Despite all the efforts, baby succumbed to the death on day 4 of life. Complete heart block. Out of baby's body sent to the autopsy, this is the histopathological finding showing biventricular excessive fibrovascular proliferation in endocardium, and this is the violet calcification also noted. Biventricular fibrosis was autopsy finding.
Mamta, can you share the slides? Mamta? Mamta?
1 minute, sir. Hello, sir.
We are losing your slides.
Problem is coming, sir. 1 minute.
Okay,
Sir. Yes, sir. 1 minute, sir.
Okay. By the time we get Mamta's slide, we are going through a case history of a newborn baby who presented to us and with a heart block. So incidentally, we had diagnosed retrospectively the incidence of the autoimmune disorder in the mother that we have done as a retrospective aspect, because this was not an usual case where we diagnosed heart block at 18 weeks of gestation. Are you okay to start, Mamta?
Ji, sir. Ji, sir.
Yeah.
Coming to the discussion part, AV block defined as a delay or interruption in the transmission of an impulse from atria to ventricle due to an analytical or functional impairment in the conductive system. The conduction disturbance can be transient or permanent, with the conduction that is delayed, intermittent, or
Mamta, your screen not moving, Mamta.
Mamta, you can go ahead. Yeah.
So the coming to first degree AV block, where the PR interval is prolonged. However, every P is followed by QRS complex. That is type 1 or primary first degree AV block. In second degree AV block, one or more, but not all P waves are blocked. Into type 1 second degree is Mobius type 1 Wenckebach phenomenon. In that, there is a gradual prolongation of PR interval until the 1P is dropped, being conducted from QRS. This against with gradual prolongation of P and dropping of P. Mobius type 2, in that the interconductive wave without prolongation of P interval. And in the advanced secondary block, 2 or more consecutive P wave fall to that's 2:1 or 3:1. Where atria beats on its own pace and ventricle beats on own pace. Causes of the congenital heart block. Various maternal factor and fetal factors are considered. Maternal factor being metabolic disease like type 2 DM, phenylketonuria, maternal drugs, antenatal, anticonvulsant, lithium ACE inhibitor, retinoic acid, SSRI, and NSAID. These are commonly attributing to some anatomical defect leading to congenital heart block. Various viral infection in the mother, Coxsackie, adeno, cytomegalovirus, causing myocarditis and ultimately leading to heart block. And most common feature in the mother is autoantibody transfer to the fetus. That is anti-Rho and La antibody, anti-RNP also. Fetal factor, where is congenital structural anomaly like heterotraxy syndrome, TGA, L-type, atrial and ventricular septal defect, TOF, and pulmonary stenosis. Some genetic channelopathy like long QT syndrome, Brugada syndrome, sick sinus syndrome, and various polymorphic ventricular tachycardia like catecholaminergic thing. Autoimmune heart block is that is body congenital heart block is also known as a complete heart block and third degree, in which passive acquired visitors placenta transfer of the maternal antibody specific to RO and LA. The fetal conducting system being damaged as starting being damaged as early as 11 of gestation, and gradually inflammation, calcification, and fibrosis, ultimately leading to a blockage of the signal conduction at AV block in structurally normal heart. Pathophysiology being here is the graphical presentation. It is hypothesized that this antibody binds to L-type calcium receptor on the fetal cardiomyocytes, preventing the uptake of the calcium, possibly leading to pathological, that is non-physiological apoptosis. And alternatively, the pathogenesis being they may bind to the internal target antigens released during the physiological apoptosis, which is then opsonized by the maternal circulatory and maternal circulating antibody. This lead to activation of the toll-like receptor 7-8 cascade, and both of this hypothesis result in ultimately inflammation, fibrosis, and eventually calcification of the cardiac system, which is causing a disturbance in the conduction. One beautiful article published in 2015 in Nature Review Rheumatology, the clinical spectrum of autoimmune congenital heart block, This is a systemic review. They reviewed multiple studies from various centers. What they found was irreversible complete AV block is principal manifestation in more than 80% of the reported cases of autoimmune CHB. 20% of the case of the autoimmune CHB are fatal, and 64 of the live births require a pacemaker. 1.7% of the pregnant women positive for anti-RO and anti-La antibody have a baby with autoimmune congenital heart block, but the risk climbs to around 60 to 80% for the mother who have previously affected pregnancy. 85 of the mothers with the children with congenital AV block are asymptomatic for the connective tissue disease prior to the conception, as we have seen in our case. In addition to 98% of the women in fetal congenital AV block was detected had a previously healthy child. What can be the fetal feature for immune congenital heart block? They can present at as AV block, endocardial fibroelastosis, or valvular disease. AV block is the most common form of manifestation, and usual time is around 18 to 24 weeks. The second form of cardiac presentation in immunely affected children is endocardial fibroelastosis. Is a form of myocardial fibrosis. Referring to that review, previously we have shown that 7% of the fetus with the congenital heart block was having endocardial fibroelastosis feature. How we can identify in echo? There are areas of patchy echogenicity, that is indicative of fibrosis on endocardial surface of the heart. It can lead to dilated cardiomyopathy and myocardial dysfunction very commonly. The next form of presentation for immune cardiac affection is valvular disease. It can be seen with a congenital heart block in 1.6% of the cases, involving mainly AV valves, tricuspid and mitral. Referring to that review, we previously discussed. What they found is here, the figure A was showing age at the diagnosis of the congenital heart block. The more than half of the presentation is between 20 to 24. Now, around 9% were presented between 18 to 19 week of gestation. Only 4 cases were presented before 18 week. Around 16 week was the presentation for the 4 cases. The remaining presented at 30 to 34 week, 25 to 29 week. This is at around late preterm to term, and the neonatal presentation in around 2% of the cases. Figure B was showing the congenital heart block type. Most commonly in 81% of being type 3, that is 3rd degree complete congenital heart block. Type 2 in around 10% and in around 6% type 1, 2 or 3, and type 1 is in 3%. Coming to the other cardiac complication associated with complete heart block, hydrocephalus, heart failure, fibroelastosis, pericardial effusion, and valvular disease. Now, what are the possibility of the mortality? When we are in vitro mortality is seen in around 70% of the case, according to that review. Less than 1 year, around 25%, and after 1 year, the mortality decreases to 5%. Various case studies have been published. This is one of the case studies showing 3 to to 4 cases of the complete congenital heart block. What they found, while the congenital heart block is the most widely studied and recognized aspect of the fetal exposure to anti-RO antibodies, they've seen in anti-RO and LA. There are numerous report of the complication beyond those illustrated in this report. They have mentioned signs as bradycardia, first degree AV block, second degree AV block, atrial flutter, tricuspid valve cord rupture with a severe tricuspid regurgitation and dilated cardiomyopathy. Coming to antenatally management, fetal echo evaluate the mechanical consequences of the arrhythmia. How is the condition of the chamber, how are the valves and all that. AM mode and or the Doppler echography for the conduction, type of the conduction defect. And if we are finding those, we can go retrospectively for the maternal immunoassay, or whether if mother is known autoimmunity patient, we can go for the evaluation. Now, what are the screening recommendations? Accurate measurement of fetal arrhythmia requires a careful Doppler and M mode examination. At any gestation, abnormal fetal rhythm, which is not clearly due to atrial ectopy, that is the commonest non-sinus rhythm in the fetus, warrants a further expert evaluation. Screening echo weekly starting from 16 week through the 26th week. We can reduce the frequency after 26 week if we are not finding the congenital block. Babies of anti-Rho and La positive mothers who develop the cardiac failure in the absence of heart block should be screened for other cardiac abnormality such as endocardial fibroelastosis and valvular disease. So the congenital heart block, not the whole and sole cardiac manifestation for the autoimmunity factor. In addition, mother delivering the baby with endocardial fibroelastosis or valvular insufficiency should be tested for anti-Rho and La autoantibody even in the absence of AV block. One suggested algorithm they have provided: autoantibody sequential study and clinical evaluation of the women who have babies with congenital heart block of any degree, congenital valvular disease, or endocardial fibroelastosis in an otherwise structurally normal fetal heart. That is immune related thing. We have to test for lab. If it's positive, confirming autoimmune congenital heart block. If it's negative, we should go for RO52 or RO60 autoantibody. If it's positive, it's autoimmune CHB. And if it's negative, we should use the native antigen for RO60. If it is coming positive, it is confirming the diagnosis. If negative, then we can say that it is non-immune congenital heart block. We should evaluate the mother for underlying incipient cystic autoimmune disease, SLE and primary Sjogren syndrome. We can find it out. And otherwise, if we are not finding any systemic autoimmune disease, we should be keeping a mother for annual follow-up regularly. This one suggests algorithm for anti-RO and LA pregnancy. As we've already talked, that routine screening investigation to be done. PR interval more than or equal to 140 seconds, that is 2 SD, and or moderate tricuspid regurgitation should take within 24 to 48 hours. If the deviation is more than 3 SD, that is more than 150 millisecond, we should consider dexamethasone 4 milligram for 1 week. If we are facing secondary or alternately second degree or third degree AV block, or AV block with sign of fibroelastosis, myocarditis, heart failure, or feature suggestive of hydros, we should consider dexamethasone 4 milligram daily for 4 to 6 weeks. In third degree AV block and no hydrops fetalis, we should monitor closely for the feature of hydrops fetalis. Third degree AV block and severe hydrops fetalis, dexamethasone 4 to 8 milligram daily we can consider, plus IVIG, query apheresis, or consider termination also if the baby is hydropic. Various reviews and various literature, they find that the complete heart block, that is third degree, was identified as irreversible despite all therapies attempted to date, including the glucocorticoid, apheresis, IVIG, or hydroxychloroquine. The second degree heart block may be reversible, but it also may progress to complete heart block despite all above therapy. The upcoming study, this hydroxychloroquine to prevent the recurrent congenital heart block in fetus in anti-Roe and anti-Roe mother. The study published in 2020. It was a multi-center, open label and single arm trial. So in that study, the participants were a mother who is Rho positive and with a previous pregnancy complicated by the CHB. They were recruited and they received a 400 milligram hydroxychloroquine prior to the completion of the gestation week 10. And that they continued throughout the pregnancy. And the primary outcome, they observed that the second or third degree congenital heart block anytime during the pregnancy. Secondary outcome they monitor was the isolated endocardial fibroelastosis and primary first degree congenital heart block at birth and screen rash. What they found in that, there is data that supported HCQ significantly reduced the recurrence of the CHB below the historical rate by more than 50%. The routine rate is 16 to 18% in the for the recurrence. Here they found incidence in around 7.4% only. We are following the fetus for autoimmune features and the progression of that autoimmune cardiac involvement. What can be the indicators for the poor fetal cardiac outcome? Ventricular rate less than 55 beat per minute, features suggestive of hydrops fetalis, increased cardiothoracic index, any AV valve regurgitation, and low aortic flow velocity. Postnatally, when we should consider the pacemaker. The article published in the Annal of Pediatrics Cardiology 2019, they have graded and provided various level of evidence, and they indicated that the infant with normal anatomy and ventricular rate less than 55, we should consider pacemaker. The infant with other structural congenital heart disease and ventricular rate with the rate less than 70 beats per minute. Any feature suggestive of ventricular dysfunction or ventricular ectopy, the symptomatic bradycardia or low cardiac output. For infant older than 1 year with average heart rate of less than 50 beats per minute, with significant ventricular pauses or symptom consistent with the chronotropic impairment. This is the old study. In that 2000, they have performed in various institutions, various 30 years of experience, outcome of the children with fetal, neonatal or childhood diagnosis of isolated congenital atrioventricular block. What they found as a risk factor for the mortality is fetal diagnosis of congenital heart block, fetal hydrops, and ventricular endocardial fibroelastosis associated with more significant death outcome. In this study, they have evaluated the need for the pacemaker, early pacemaker insertion and repeat pacemaker insertion. What they found, the babies who have diagnosed prenatally with a congenital AV block were having more incidence for more need for early pacemaker insertion, and repeat pacemaker insertion rate was high in those babies. Referring to the same Nature Review 2015, they evaluated endocardial fibroelastosis is a major risk factor, and what they found, at around 19 to 20% were diagnosis EFE in absence of congenital heart block in autoimmune cases. The AV block is associated in around 81% with EFE. The outcome of the baby with endocardial fibroelastosis was detailed by a study of 103 cases. Around 14 studies, they have evaluated 103 cases for the outcome. What they found is the death is there in around 51%. And when the fibroelastosis is associated with concomitant cardiomyopathy, the death was 100%. Whereas maternal antibody associated with endocardial fibroelastosis, most commonly asymptomatic ROLA carriers were there, around 55%. SLE, diagnosis of SLE was established in around 29%. Other autoimmune disease like mixed connective tissue, Raynaud, and some rare cases, arthritis, hypothyroidism was there. And the need for pacemaker was around in 76% of the cases. This was the gross idea of the severity of the endocardial fibroelastosis. Now coming back to our case. Our case, early intervention was needed. According to our center's experience, we have treated at the same age of life, we have pacemaker inserted, the baby with outcome was good. What was the different thing in this baby? The major mortality we have attributed to endocardial fibroelastosis. So we are thinking in the line of whether we should consider as a poor prognostic factor endocardial fibroelastosis to be considered as a poor prognostic factor while doing antenatal counseling, whether we should discourage the mother for the continuation. Thank you.
Thank you, Dr. Mamta, for beautifully presenting this case. Just I will sum up in 5 minutes. So congenital heart block is a rare disorder, around 1 in 15,000 to 22,000. And even though SLE is seen in mothers, only 3% of mothers, in fact, will have babies with congenital heart block. However, the more worrisome issue is the recurrence rate is nearly 18% in such mothers who are having a previous history of anti-LO RA exposed pregnancies. So that is the one thing you should be addressing this issue. What is the plan for the pregnancy for the next time? So then the presentation, what we had was a different type of presentation. Usually we diagnose at 18 to 24 weeks, but this is a different scenario. We diagnosed retrospectively the presence of autoimmune disorder in the mother post after delivery. So the answers to be sought for this in case is a role of any specific medications in the mother which could have prevented this issue, like the role of hydrochloroquine, which already has been started, role of terbutaline, the role of diuretics, the role of digoxin, the role of plasmapheresis, the role of any other things which have been thought in the mother for the next pregnancies. And the role of autopsy, we have found endocardial fibroelastosis. We know that it is a very high risk mortality, like nearly like fetal hydrops. Outcome is nearly 100% mortality in reported case reports. So the learning points in this child case, what Dr. Mamta has presented is how to approach retrospectively, look closely, look for the findings in the baby, look for the ECG findings, look for the clinical manifestation, early pacemaker, the heart rate is less than 55, and proper counseling of the parents, with the background of the disease. So any questions will be appreciated. Any doubts? So for the interest of the people who are attending, let me put out some questions. Can somebody enumerate the mechanism of action of hydrochloroquine in the mothers? In this case, how it acts, how it prevents, and what is the role of hydrochloroquine in pregnancies? So, Dr. Mamta, you want to answer?
So immunomodulator, they prevent the recurrence of the things, sir, in the future pregnancy only, not for the interest of the current pregnancy. It is useful, sir.
Okay, very good. Okay, there are toll-like receptors in which the usually hydrochloroquine acts, and this same toll-like receptors are attributed to be having a role in the case of autoimmune secondary to the systemic lupus in the baby. So it is through the toll receptors it acts and prevents the autoimmunity. Now, somebody can you answer what is the role of terbutaline in case of mothers? Terbutaline. Okay, terbutaline is a sympathomimetic drug. It is helping to increase the heart rate and prevents symptoms failure. Yeah. Can anybody ask some questions? Dr. Mamta will be happy to answer.
Sir, one question they've asked, sir.
Yeah.
Hello, sir.
Yeah,
Sir.
please.
One question I've seen in the chat box, sir. What about antenatal steroid in congenital heart block? They've asked, sir.
Okay, you want to address the issue?
I'll try, sir.
Ah.
One, hello, sir. My screen is visible, sir.
Yeah, your screen is visible. You can go ahead. Your screen is visible and you're audible also.
So with regard to this, I would like to connect PRIDE study. Prospective evaluation of the fetus with autoimmune associated congenital heart block, followed in PR interval and dexamethasone evaluation. That is, they've concluded the 40 women with anti-RON. So what they've found here, what is the, this was the thing with dexamethasone and untreated with dexamethasone. Death rate, delivery rate, prematurity, and pacemaker at birth and 1 year of age, that was almost similar. And we should weigh the benefit of weigh the benefit versus risk. What is the risk of dexamethasone? What is the risk of thing? Advantage. According to this study, the much advantage. And in our case, we found that 33 week we with the mother was outbooked before that. So in our study, we have not started. The baby was already was having complete congenital heart block since period. Sir, you want to add up anything, sir?
Yeah. So the idea of all the steroids were coming into this picture when they started aggressive management of antenatal diagnosed congenital heart block. The medication in the pipeline were plasmapheresis, metal anti-adrenergic agent, and adrenocorticoids. Now coming to the topic of adrenocorticoids, the decision was to select an adrenocorticoid which is not distracted by the placenta. Now there comes the answer of dexamethasone, which is easily bypassing the placenta without deteriorating in the system. And it has been shown to reverse second degree heart block. And the idea is to give for 4 milligram once daily for around 6 weeks. And if there is a reversal, to continue till pregnancy. If there's no reversal, it is futile to stop. And we should be very careful that it is less active in cases of complete heart block, third degree heart block. And when the third degree heart block is not responding to treatment for more than 3 weeks, there's no point in continuing for the management. Now, most important thing is dexamethasone we are giving in diagnosing heart blocks antinatal, but majority of the first degree heart blocks go unnoticed in pregnancy. Even though currently we are using auscultation method, echo method, and continuous monitoring of the mother as a mandatory for the diagnosis of heart block. Some first degree heart block since even with recent advances go unnoticed. So even will not be surprised to in that case of our case to have a baby like this will be without any manifestation antenatally. That is also a common picture because most of the first degree heart block goes unnoticed. And as per the discussion, there is a progression of first degree to secondary heart block over the time. So dexamethasone still holds good. And problems as Dr. Mamta has touched, the role of dexamethasone induced hypertension, diabetes, bone density, decreased bone density in the mother, as well as the risk of oligohydramnios, IUGR, and multiple doses causing decreased neurodevelopmental outcome in the long term is a big question. So as of now, dexamethasone 4 milligram once daily for 6 weeks. And if it is responding, to continue till pregnancy is the current practice. Dr. Mamta, what is a pacemaker you want to add?
Sir, initially we tried with temporary pacemaker, sir. Transvenous route we tried, sir. After that, we were not getting a proper response, and then we went for the permanent pacemaker insertion. Actually, in hello.
You're audible. Yeah.
Sir. Sir, finally we ended up with permanent pacemaker, sir.
So the idea of temporary and permanent pacemaker, eventually a baby who is surviving complete heart block in the neonatal period, at one part of time, may ultimately, nearly 90% of them will ultimately go for a requirement of a permanent pacemaker, regardless of the age of onset of symptoms. That is the broad discussion. Now, to go for a permanent pacemaker at the earlier stage. Now, when to go for a permanent pacemaker at earlier stage? If the child would have shown symptoms of congenital heart failure leading to significant cardiomegaly or persistent heart rate less than 55, not in our case, in spite of treatment. And these are indications where we would have thought of a permanent pacemaker, but the anesthetist and surgeon will be jittery to take a small baby for a theater for a permanent pacemaker. So in a scenario like this, ideally we can go with a temporary pacemaker, stabilize the baby, go with the medical management. At some part of time, ultimately the child is going for a permanent pacemaker. There are some apoptotic markers also for the people who are interested in research. There are markers like tunnel apoptotic cells, and at 22 weeks of gestation, they are using the apoptotic cell ratio to the normal total cell ratio. And any incidence of apoptotic cell ratio more than 34, tunnel apoptotic cell ratio more than 34, indicates a high risk of a congenital heart block. And predominantly, we see left atrial dilatation, left ventricular failure, and mitral regurgitation in childhood. And sometimes it is always not uncommon to see tricuspid regurgitation and right-sided involvement at the newborn period. It will be happy if some of you can share similar cases at your own centers and how it was managed differently. In the interest of time, we'll be closing in another 5 to 7 minutes. If anybody wants to share their own experiences, we'll be happy. Dr. Mamta, your final submission.
Thank you, everyone, for the patient hearing. Thank you, sir. Thank you so much for the guidance and the mentoring my session.
So to learning points, congenital heart block is something which is presenting less than 20 days of gestation, and with a background history of antenatal autoimmune disorder. And there is one term called genetic congenital heart block, which is manifesting as an isolated heart block without any structural anomalies. So more and more of genetic heart blocks are being diagnosed over time. And the manifestations we have already discussed: type 1, type 2, type 3. Type 1 is prolongation, and type 2 is Mobitz 1 and 2, and type 3 is a complete dissociation in our case. The management treatment is usually early pacemaker if the heart rate is less than 55, as in our case, and going for an antenatal treatment of the mother in case of hydrochloroquine, diuretics, digoxin, plasmapheresis, IV immunoglobulin. The list is so long. And poor prognostic indicators: heart rate less than 55, and congenital elastofibrosis, as in our case. Presentation as hydrops and early manifestation, early presentation, all are poor prognostic indicators. And a wide QRS with a complex ventricular ectopy, that is one finding in a continuous QRT monitoring. Wide QRS with a complex ventricular ectopy is another poor prognostic marker. And any associated significant congenital anomalies always go with a poor prognostic marker. And counseling aspects, very important. Counseling for the next pregnancy: look for the manifestations of abnormal heart rate rhythm in the early pregnancy, catch them early, continuous monitoring of the mother, and treatment with hydrochloroquine or terbutaline, digoxin, or plasmapheresis or IV immunoglobulin, as research will add the future. And look forward for a healthy baby. And if manifestations, once they settle, they are always going for a need of a permanent pacemaker at some point of time. So if there are no further questions, I am thankful for all for spending the evening with us. Thank you.
For unconditional support and guidance in addition.
Dr. Ahmed sir, can we close? Sorry, Dr. Abdul sir, can we close?